So lately, medicine has been challenging for all, given the recent and ongoing COVID-19 pandemic. We're all still, depending upon where we are regionally in the country. I'm being in New York, so we had a busy March and April, but certainly, this is something we're facing until we have either vaccine therapy that's very effective, or combination or treatment options for patients who develop an infection from COVID-19 that we know we can successfully treat them as we do other infections or viruses, depending upon what that virus is. And so I think many of us are clearly on edge, given what we went through, certainly in New York, and my experience with COVID-19 in our CLL patient population. And certainly I do think our patients are at a higher risk of complications from COVID-19, and hopefully there will be data forthcoming about that as we've put some data together. And certainly I think there's already been some publications from abroad looking at cancer patients in general and how those patients don't do as well from COVID-19 as opposed to non-cancer patients. But certainly I think our CLL patients are at risk for complications as well. And so it's, I don't, clearly, in terms of treatment, I think that certainly this is something that's going to evolve, and we're going to need more data to elucidate if that's going to be a problem. Certainly, I don't necessarily recommend that patients start earlier or do things differently in terms of when they need treatment for their CLL. So, I still recommend active observation and monitoring until such time that the disease really requires therapy. So we're not treating patients necessarily earlier because of the COVID-19 pandemic. But there's no doubt when you have these conversations with your patients and you're talking about options of therapy, when you're talking about oral therapies versus oral IV or hospitalization and monitoring and more frequent visits and things like that, having an oral BTKI, monotherapy is certainly more appealing to patients because obviously the frequency of their office visits and side effect profiles, tend to be possibly, obviously less than, let's say, initially the monitoring required for a Ven antibody combination. And so that needs to be taken into consideration and in discussion with your patients. And so we will probably, I would imagine, see more favored use with a BTKI in possibly in that setting or discussion for sure coming out, because patients are still nervous about coming to their doctor's office or to hospital, if they need a hospitalization. But I don't think our recommendations should be different. I mean, you have to, we have now available great therapies on both fronts. And so time limited versus BTKI, I think those discussions are still all relevant and paramount, but patients may choose to do that because of the fact that in the beginning regarding the ramp up, they really need to be monitored more closely. Now, are there ways to finesse that ramp up? Are there differences? Can we start with an antibody and debulk the patient and then can do the Ven as an outpatient? So there are obviously, and actually there are clinical trials that looked at this already. So certainly we know that doing that can potentially debulk patients sooner and then have them do this as an outpatient. This leads into some of the combination strategies that are being evolved, prior to the pandemic, when we look at combinations such as ibrutinib and venetoclax or a BTK inhibitor and venetoclax, right? So if you look at those combinations, then you can debulk them that way as an outpatient and then do venetoclax ramp up as an outpatient as well. So certainly different combination strategies can do that to make the ramp up easier for our patients. They may not require hospitalization then, but they still need to be monitored. So even if the Ven ramp up is going to be as an outpatient because you've debulked them adequately and they're no longer high risk, you're still going to have to monitor their electrolytes. They'll still need more frequent lab checks because they're still doing that 5-week ramp up, even if it's as an outpatient. So certainly that still needs to apply regardless. So there might be more frequent issues, but you might avoid the hospitalization. So definitely there are ways to think about how to strategize those patients. Of course, the BTK venetoclax combination is still clinical trials. And I think it's appropriate that those individuals are on clinical trials to do that, because we're trying to learn about how that combination, we know it's effective. The combinations, whether it be with a BTK and venetoclax or other combinations, we know that in frontline therapy, these combinations are very active, have high efficacy, but ultimately we're trying to learn what is the response duration of these combinations? What is the PFS of these combinations? Are we doing something different? Will the, when patients relapse, how do we salvage those patients? So I think that, if they're not approved, I still, argue that those patients should be put on a clinical trial, so that we can monitor what, what the effects of these combinations, these novel combinations are, so that we'll gain information about how to sequence therapies, how to salvage patients with therapies, because we don't have that data. So yes, I think there are many ways to use, monoclonal CD20 monoclonal antibodies to debulk patients if you're going to use venetoclax, and then sort of strategize that for doing outpatient therapy. And that data is certainly there and available and can be used now. But some of these more novel combinations, I still argue that patients should be on clinical trials to evaluate them for how they do.